I have the very hard mission to draw some conclusive remarks. I've been very, very interested and so grateful for all the speakers for the terrific talks. And I have tried to gather some questions reuniting and with crosstalks between the different topics, which are more questions for the future. The most important thing is that all the different specialties, clinicals, preclinicals, medical imaging, PRT, all are very complementary, and we should increase our collaborations in the next future. For example, I had some questions and just food for thoughts regarding the impact of PRT on methylation. And for example, we don't really know what is the impact of PRT on tumor methylations. And maybe there are some changes within the actors of epigenetic regulation, and we should understand that, because one of the possible way to overcome resistance would be combinations. This has been also suggested before, and probably, but which actor of epigenetic should we act on? Would it be methylation, demethylation, or histone configuration? And I think that this is a really important task for the future. Also, we have mentioned earlier that alpha cell types of pancreatic neuroendocrine tumors, one specific subtype has a signature regarding hypoxia, but I think that I remember from my early classes that hypoxia may be a factor of resistance of radiation therapy at large. And maybe it could be also some way to understand the resistance of PRT, to look into hypoxia. And I know that there are some also nuclear imaging, new markers of hypoxia. We have been talking about FDG for years, but maybe we should also look into CA9 PET imaging, for example, and maybe we could be able to identify alpha type intermediate pancreatic neuroendocrine tumors. I have also learned from Marianne great talk that maybe cumulative surgical resection would be interesting in order to gain long-term survival, which means that probably that debulking, maximal debulking would be important. Maybe partial response also would be important. And one thing we should look into is, should the achievement of partial response, is it really an objective goal? Is the goal to achieve progression-free survival? Is the goal to achieve overall survival and to resemble that of the general population? Or is the goal to have objective response? And in early studies, I think that objective response with PRT is not really correlated with progression-free survival. And maybe there is some mystery to unlock here and to understand why does the patient with the highest response seems to be also the patients that will progress the faster. And finally, we have been talking about selecting patients with early prediction of response, and maybe those patients should be looked into more deeply for combination with alpha therapy. Or maybe if after 1 or 2 cycles of PRT, we observe that beta emitters, which means lutetium DOTATOC or DOTATATE, does not work as planned. Maybe these candidates should be the good ones for combination, or maybe switch the emitter and maybe give the patient some alpha emitters at that time. And finally, regarding the alpha therapy, maybe we should look into the DNA response. Is it different from between the beta emitter and the alpha emitter? And also the DNA repair pathways. So we could identify the right radiosensitizers and the right combinations in order to enhance the efficacy of PRT. Thank you very much.